This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It is May 2021. We're back for another great month. Ryan, you doing it good?
Oh, yeah. It's a beautiful fall day.
Fall? Yeah, I guess that makes sense down there. Okay.
Well, they call it autumn.
Autumn. They do indeed. All right. Well, before we get too much into the weather, why don't we just jump into this? So, our first article is the Association of Gun Violence with Emergency Department Visits for Stress Response Complaints. And the lead author is Eugenia South. So I think most of us would agree that there is an epidemic of gun violence in this country. And rightly so, we focus on the direct effects on the victims of this violence and their families. But these authors point out that the effects of gun violence is far broader reaching than just the victims and their direct families. And they go on to postulate that people living close to gun violence experience both acute and chronic stresses which can affect their health. These authors hypothesize that ED encounters for stress response chief complaints would increase in the short term for people living nearby a shooting event compared to with before the shooting. They performed a location-based before and after neighborhood study of locations of all police-reported shootings taking place in 7 zip codes in Philadelphia from 2013 to 2014. They examined zip codes that surround the 2 major academic hospitals for which their health data was drawn. They defined stress response diagnosis as the following: acute myocardial infarction, congestive heart failure, hypertension, chronic obstructive pulmonary disease, asthma, anxiety, depression, and substance use. They then developed a predefined list of chief complaints associated with these diagnoses. They compared the number of people presenting with these complaints before and after a shooting event. So a total of 513 shooting events occurred involving 535 individuals during the study period in the study geographic location. 17% were fatal and 3.8 were police officer involved. A total of 19,906 stress response chief complaints were included in this analysis. The mean age of these patients was 50.3 and 91% were Black. The authors essentially found no evidence there was an increase in stress response complaints before and after a shooting. They report that there was an increased number of patients presenting with syncope after a shooting event, but given the number of variables analyzed, this is way more likely due to chance alone rather than a true association. So I think it's a really interesting study in what they tried to do here, but just because they weren't able to find any real signal, it doesn't completely discredit the underlying theory. I got to say, I think this was way too blunt a tool to attempt such a measure of a nuanced phenomenon. I think if you want to look at this, you kind of have to look at it in different ways to see what you come up with.
Yeah, I mean, the methodology here is one of the big weaknesses. It's using emergency department presentations for these specific coded chief complaints as a surrogate marker for increased stress and anxiety in a community following gun violence. I think that's where it really breaks down, is that this is such a surrogate for the actual impact on a community that it's so hard to make that association and then actually say it's reliable, that one signal or no signal or anything, it neither rules in nor rules out the association of increased stress in a community with gun violence. It's a sad statement on America, of course, that we have sufficient numbers of shootings in such a small area to perform such a study on like this. Hooray, fertile ground for research and analysis.
I mean, well, that's the whole other part here. I mean, can you really find a before and after? There's so many shootings, like one would imagine they're living in chronic stress at this point. I mean, it's a sad statement that within a year period in this small geographic locations, they had 513 shooting incidents.
Yeah, I mean, I guess that's the other thing. It's like, how do you? It's not like it's it's a Sandy Hook or someplace that has a very rare occasion of which there's a catastrophic event. This is almost a daily occurrence. So, I mean, I don't know how you could actually have a cause and effect from any one of these shootings over the course of 2 years.
Right. So I think, like I said, I think we need to find kind of more nuanced and more creative ways of looking at this because this doesn't necessarily rule out this phenomenon.
Yeah. I thought it was a very interesting research question to start with.
Definitely.
And moving on, another article from this upcoming issue is called Between Emergency Department Visits, the Role of Harm Reduction Programs in Mitigating the Harms Associated with Injection Drug Use. Our lead author here is Wendy Matias Kostanopoulos, and they're at Massachusetts General Hospital and Harvard Medical School. And it's actually kind of just a big review article, overview of the injection drug problem in the United States. And it starts with a scope of the problem and relevant terminology because it's not really of any surprise to any emergency physician anywhere that injection drug use is a serious public health problem. Estimates are that about 6.6 million people in the United States have ever used injection drugs during their lifetime. And now, overdose deaths have increased about 400% over the past 2 decades, and those are primarily related to opioid overdoses. The bulk of the article, however, reflects the title, discussing the various potential venues for harm reduction. This starts conceptually from changing the fabric of society to other systemic interventions such as new legislation, increased prevalence and distribution of naloxone rescue kits, all the way down to the sort of actual individual level interventions for primary and secondary prevention of drug related morbidity and mortality. Most relevant to this article, as judged by the authors to the emergency department, is an extensive discussion of syringe services programs, either for clean syringes to reduce transmission of infection, or supervised injection services to reduce fatal overdoses, along with evidence in support of the implementation of these services. Barriers mentioned by these authors are, unsurprisingly, primarily cultural and political. In these contexts, then, overall, the authors call primarily on emergency physicians to do two things. First, advocate for syringe services in their communities, and then secondly, to refer patients to these services when available. It's a fairly long article and goes into a fairly robust detail on these different things. So if you are interested in this topic, it's a good piece to look at.
Yeah, really nice review. And I think anyone who's interested in kind of bringing some of this stuff to their ED, this is the article to read.
Well, I think it's also people who are active in their community as well. Whether you're on local city councils or active in your city and state government. I think there's a lot of physicians who have both leadership roles in their hospitals, but also in their communities. And this is a nice piece to be able to take to some of those other, maybe potentially even lay people who are interested in the topic, to help bring them along and to have them look at the evidence behind how much these syringe services can contribute to harm reduction.
Yeah, exactly. So our next article, Fair Play, application of normalized scoring to ED throughput quality measures in a national registry. And the lead author is Arjun Venkatesh. So I think we've all been exposed to CMS measures in the emergency department, whether it's time to antibiotics and sepsis or pneumonia or, the screening for suicide screening, so on and so forth. Some of us are probably not as aware of, unless you're on the administrative side of emergency medicine, are the quality metrics of the emergency department as a total. And one of the big ones used is ED throughput, or the time from ED presentation to discharge. It's a common used metric by CMS to report quality and efficiency. And from my understanding, the thought is simple. The faster patients can be moved through the emergency department is a metric for the quality or efficiency of that emergency department. The thought being, the emergency department to take longer to get tests done, get CT scans done, get patients seen and discharged is a metric of the inefficiency of that system. But measuring these times is not always so straightforward, and they can be affected by other things other than just ED efficiency. So annual ED volume specifically, if you have two equally efficient emergency departments, but one is seeing far more patients, obviously throughput time can be affected by that. And so these authors wanted to actually devise a system that could control for these metrics, since they are being measured by the CMS, and make a more fair comparison to be able to control for ED volumes. And so they thought to develop an adjusted EC throughput quality metric. Using the 2017 Clinical Emergency Data Registry, they assessed the overall association between 12 volume-based ACEP ED throughput measures, 6 for adult, 6 for pediatrics, and the ED visit volume. They found that increasing ED volumes, not surprisingly, was associated with increasing ED throughput times. And so in ED groups that had at least one large emergency department with higher volumes ended up having longer throughput times than ED groups that had no large emergency departments in them. The authors then examined various methods to categorize ED groups into quartiles of the highest or lowest throughput times. And they found that groups with the largest EDs were consistently in the lower quartiles compared to those without large EDs. So they did a number of things to try to control for this. And what they found was the weighted standardized score led to a more equal distribution of large volume emergency departments. And this essentially score looks at how far away an emergency department is from the mean score. For example, if an ED with a performance score close to the average score would have a standardized score of 0. And as the throughput time deviates from that average score, your score would go up or down accordingly. And so this is a fairly technical paper that has a very kind of niche analysis that they're looking at. And obviously it's making a number of assumptions. Most importantly, is ED throughput time an important metric in general? But I think if CMS is deciding to use it, and if we think it's a valuable metric to measure, this is an interesting way to go about maybe balancing the scales a little bit. I think for people who are really interested in this administrative side or so, this is a nice paper to read.
Yeah, I mean, besides any one of these specific normalized scoring systems, I think the most sort of apparent thing to me is that how inequitable these quality measures are, and that they're such a blunt instrument for measuring how well an emergency department is functioning, that they just applying the same rule to a whole bunch of different emergency departments is clearly a recipe for disaster. Which, of course, probably doesn't matter to the people applying these quality measures. They just want to see people do better. But as far as like a punitive measure against emergency departments that are struggling with different constraints and different resourcing and different stresses than other emergency departments, it's clearly it's not an inequitable tool, or it's not an equitable tool for evaluation.
Yeah, I mean, the other thing is, history would tell us that the way we improve these scores is not to actually improve quality metrics, but we find a way to cheat the score in some way or another more than that. And so, do these scores ever actually translate into improvement in quality in patient care? I'm not sure.
Oh yeah. I mean, when you talk about time to first contact with a medical professional, and it's not time to first contact with an actual emergency physician doing a full, complete evaluation. It's some other, taggable event in the patient's workflow in which a medical professional is somehow involved. It's not true. We game the system whenever there's a measure like this. That's no surprise to anybody.
Right, and I would go even further. Does time to seeing a doctor actually matter? Most of the time, probably not. Right.
What about time to antibiotics and sepsis? Now, there's a measure that we haven't gamed. We've just decided to give everybody antibiotics when they arrive.
Yeah. I think in a couple months we'll be discussing this, so stay tuned.
You mean like again?
Yeah.
Can't stop, won't stop. And maybe we'll even have some sort of machine learning article to go through. We don't have a machine learning article this month.
Yeah, I know. We'll probably have to do 2 next month.
I'm sorry. We apologize for the omission.
We will find 2 machine learning articles that show us moderate distinction between 2 things that emergency physicians probably can just look at and make a clinical decision.
Yes, with the standard limitations of generalizability and other things, and that they haven't been tested against actual clinical care. Okay. Back to topic. Staying really on topic, this entire issue is really about various public health issues. The next article that we're going to cover is called "The Influence of Social Determinants of Health on Emergency Department Visits in a Medicaid Sample." Our lead author here is Melissa McCarthy. They are at George Washington University. And there is, obviously a certain perception. Patients coming to the emergency department frequently don't need to be there, that their primary care physician could handle some of these complaints. And that extends further to a certain segment of the population that has fewer support systems, that they even further use or abuse the emergency department for primary care problems. So do they really? This is a retrospective analysis of a prospectively enrolled cohort of Medicaid patients in the District of Columbia, specifically looking to see if the so-called social determinants of health affect emergency department utilization. These authors had a cohort of 8,943 patients, which they divided up using latent class analysis to 4 distinct social risk classes, the best features to describe them being sort of employed and fewest social risks, to another class of employed and high financial strain, to another class unemployed and limited internet and car access, and then a group that they kind of simply best describe as high risk with diverse stressors and strain. They do an extensive bit of analysis through all these various social determinants and age and various things, and look at the mean and median number of emergency department visits requiring emergency care, and the mean number of ED visits that could have been primary care treatable, estimated by coded information in the electronic health record. What's pretty apparent is, overall, many of the various social determinants are related to increased ED visits overall, both appropriate and not. And then the end result of their analysis that, yes, increased social stressors are related to increased emergency department visits. But the median is not that much different. The mean, however, is dramatically higher for those with social determinants, probably validating that perception of inappropriate ED use being driven by an even smaller cohort of high utilizers. But overall, it's a nice descriptive study, with the expected limitations relating to generalizability and imprecision around their methods. The overall findings have general face validity, although we're obviously several steps yet removed from a specific intervention to improve overall health using ED utilization as a surrogate measure.
Right. I mean, I think that's the key part is what do we do with this data? It's not surprising the things that they have, but how do we use it to change care and any kind of incomplete changes that try to adjust just ED overutilization, I think we have shown in previous studies kind of come up short. And so, these kind of have to be looked at with a much broader sense of trying to fix the underlying fractured healthcare system rather than addressing these small kind of measurements.
Yeah, and I'm not sure that their methods actually generate precise enough attribution of these, the different social determinants to actually make and design an intervention. Although you probably start coming with some hypotheses from these data, and then, but some of these obviously, like car access, internet access, unemployment, these are not sort of the sorts of things that you can necessarily make changes at an individual or even a health system level. These are things that you would take to policymakers at a larger level, and really that gets into like, let's change the fabric of society, which gets a little bit more challenging. But there may be specific targeted interventions. There are people who are doing research and work in this space, and this is just more of their foundational literature to help guide their future interventions and tests.
Exactly. All right. So let's do our last article of the month, and that is the ED awareness study, a prospective observational cohort study of awareness with paralysis in mechanically ventilated patients admitted from the emergency department. And the lead author is Ryan Papal. So, awareness with paralysis, which is essentially you've been given a paralytic, rocuronium, succinylcholine most commonly, and either the paralysis is set in before your sedative agent or the sedative is wearing off and you're still paralyzed. And this is essentially a never event for patients who undergo intubation and mechanical ventilation. And while we have data demonstrating that this occurs very infrequently in the operating room, it really is unclear how often it happens in the emergency department. Now, we do have data showing that a large portion of patients who undergo RSI in the ED have delays to receiving adequate sedation after the RSI, but it's unclear how many of these patients actually experience awareness with paralysis. So these authors conducted a single center prospective study from June 2019 to May 2020 at a large academic tertiary care hospital. The authors prospectively identified mechanically ventilated patients 24 hours a day, and patients were eligible if they were 18 or older, underwent mechanical ventilation with endotracheal tube in the emergency department, or had the endotracheal tube placed prior to arrival to the ED. They were excluded if they experienced death before discontinuation of mechanical ventilation, presence of a neurological injury that prevented them from doing a follow-up survey, transfer to another facility, or refusal to answer the questionnaire. The primary outcome was the rate of awareness with paralyzation. This was assessed using a Bryce questionnaire and the ICU memory tool. So to be considered for a possible awareness with paralyzation event, patients had to report memories of the period between losing consciousness and waking up, and had to report the sensation or feeling of wakeful paralysis and have a documented neuromuscular blocking agent on board. Patients were given the questionnaire after being extubated, but before leaving the hospital. So the authors enrolled a total of 383 patients. 7%, or 27 patients, reported memories of wakeful paralysis and were assessed for AWP. After adjudication, the prevalence of possible or definitive AWP was 2.6%, or a total of 10 patients. The proportion of patients receiving rocuronium compared to succinylcholine was higher in the AWS group compared to patients who did not experience apnea. So in the AWS group, 70% of the patients received rocuronium and only 31 received succinylcholine. So all in all, what do we actually take from this? As Michael Gottlieb states in his editorial, while 2.6% is a small number, it is certainly not trivial, and that's a decent amount of patients who are awake and paralyzed at the same time. And I'm sure some will use this to argue against the use of rocuronium and for the use of succinylcholine. But I don't think that's the real issue. The real issue here is to focus on that patients receive adequate post-intubation sedatives as soon as possible after completing an RSI, and to ensure that a paralytic has worn off before any kind of lightening of sedation occurs in the hopes to achieving adequate RASS goals.
Yeah, 2.6% is pretty high.
Yeah.
I think that's the most surprising amount from this study. So I'm really glad they did this study. This is an important study to take a look at the frequency of this sort of awareness because, yeah, like you say, it's a never event, or at least the sort of the way the anesthesia literature describes it as being, 1 in 10,000, which is basically like somebody who's got a strange. It's not a protocolized. It's not a systemic problem. It's patients who don't necessarily necessarily have the sort of same sensitivity to the medication that we're using, sort of an unexpected sort of like emergence phenomenon that's based on their own physiology, as opposed to a problem with the emergency department where we're just not paying attention and we're just distracted by too many different things. I don't know, the whole rocuronium versus succinylcholine, as they discuss, it has face validity because it's one of those the longer acting paralytic. You don't know that they're awake.
Right.
But again, the number of people who actually have this awareness is so small. The N is so tiny. Any sort of association that's reliable can't really be described. Argue again, you have the rocks versus sucks debate. But I don't think that's relevant. I think this is just a good reminder that as soon as you've got somebody intubated, that you really need to be more aggressive with making sure that they have adequate sedation in the emergency department, which is, a good reminder for all of us at all times.
Yeah, and if you want to like dive a little deeper, it's somewhat tricky to kind of definitively prove that the patient had awake awake while paralyzed. Like if you look at like all the patients that said they felt paralyzed, there were some of them who felt paralyzed but actually never received a paralytic, right? And so obviously, especially in sick patients that are being intubated in the emergency department and going to the ICU, there will be moments when they're awake and sedated to a certain degree and not paralyzed, and it might feel that way, and certainly that's scary as well. But I think all in all, a decent amount of patients here received a paralytic and felt like they couldn't move and were present during it. And so it does speak to us being better their sedatives. I would say also, if you actually read like the 10 cases, some of them actually experienced the paralysis and actually experienced the intubation, which speaks less to the post intubation sedation and rather the actual sedation during the event. So I think we have to be thoughtful at both cases, and dosing your sedative with your paralytic, timing wise, and the right dose, and then appropriately giving sedation afterwards.
Yeah, which is interesting, which is an argument against succinylcholine if you want to pit rock against socks again, because the succinylcholine with its more rapid onset is more likely to give people that feeling of paralysis before their sedative kicks in, potentially, whereas rocuronium has a more, depending on the weight-based dosing you give them, potentially a longer time of onset. But yeah, so these are interesting things to think about while reading this article and thinking about the protocols around intubation at your own facility.
Indeed. Well, I think that wraps us up for another month. As always, with any questions, comments, or concerns, we can be reached at annalsaudio@acept.org. And otherwise, we will see you all next month. This was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.